Greetings and a warm welcome to all the dignitaries present here. I'm Rimpa from Clarnet, serving as the allocated session assistant to ensure a seamless experience. Clarnet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clarnet serves as a director partner for this event, jointly hosted by Karnataka chapter of IACTA, Indian Association of Cardiovascular Thoracic Surgeons, Indian College of Anesthesiologists, Global Intensive Care Symposium, International Society of Cardiac Ultrasound, and Global Healthcare Foundation USA. And the focus of today's session is LV Systolic Function Assessment. Now I will play the ICA welcome video to welcome you all. Now, I would like to welcome Dr. Muralidhar Kanchi sir for the further proceedings. Over to you, sir. Thank you.
Thank you, Rimpa, for that introduction. And it's my great pleasure to invite you to attend this webinar on very important topic, the LV systolic LV systolic function assessment. And we have three eminent faculty from India who will be dealing with this subject: Dr. Naina Kadam from Mumbai, Dr. Prashant from Narayana Bengaluru, and Dr. Nilesh Juvekar. All the three are accomplished cardiac anesthesiologists with a great interest in echocardiography, and we are fortunate that all the three are present today to deal with this subject in the next 5 minutes to 1 hour. So with that introduction, I would like to request Naina Kadam to introduce Dr. Nilesh Juvekar. Before I actually hand over to Naina, I request all the participants to keep the mics muted till the end of the session. And questions and comments may be posted on the chat box, which we will attend to it at the end of the session. And with that, I would request Naina to start the session.
Good morning. Good morning, everybody. Today's learned speaker, Dr. Nilesh Juvekar, he doesn't need any introduction. He is consultant cardiac anesthetist at Dinanath Mangeshkar Hospital, Pune. He's a national figure in the field of cardiac anesthesia, a great teacher and academician. He has been a pillar in all the TE workshops. Today, he will be helping us understand the LV systolic function assessment by TE. Over to you, sir.
Good morning to everyone. Naina, thank you for those kind words. I'll be just sharing my screen now. Here we go. Just give me a second. My screen. Yeah. So, good morning again. Am I sort of audible? Hello?
Yes, sir, you're audible.
Okay. So, let's start. So, today the topic given to me is LV systolic function assessment. So, over the next 35 minutes, we'll see a little in detail about how we assess the LV systolic function. I have no disclosures to make. So as we all know that LV systolic function is the most common information stored, which is stored by a physician from an echocardiography. You ask anyone about the echo, the first thing he'll say is that the EF is so and so. Why is this? Because LV systolic function or dysfunction is a predictor of perioperative clinical outcome, and also it has been consistently shown to be a predictor of morbidity and mortality. It helps us to sort of stratify the surgical risks and also guide the therapeutic interventions. As we all know that it is a load dependent parameter which is described by the Frank-Starling equation. That is, by increasing the preload, we can increase the contractility. There are various methods by which we can assess the LV systolic function. It may be either 2D echo, 3D echo, M mode, or the Doppler. So LV function is assessed either qualitatively or quantitatively. So when we say the qualitative assessment, it is basically by what is called as eyeballing, in which we assess what is the degree of the systolic dysfunction. The sort of experienced echocardiographers can also label a number, sort of particular sort of range to that particular systolic function. However, it is always advisable to complement this qualitative assessment with quantitative measurements, which may either be linear, planimetric, or volumetric, right? So there are also other surrogate markers or surrogate parameters which will help us to sort of assess the LV systolic function, like the LV mass, the dp by dt, tissue Doppler imaging, the MAPSE, the LVOT ejection acceleration, and the tie index, which we'll be seeing one by one. Now, coming to eyeballing, basically it is a visual assessment of the LV function, which is based on observation of the sort of regional myocardial function, which is the sort of deformation like sort of thickening and sort of shortening, or the sort of displacement. Like they are scored as either normal or hyperkinetic, hypokinetic, akinetic, or dyskinetic. And depending upon this, they are either said to be mild LV dysfunction, moderate LV
Sir,
dysfunction, or hello. Yeah, so it is either mild LV dysfunction, moderate
Sir,
LV
sorry for
dysfunction.
the
please make
interruption,
it
sir.
full
Your
screen.
Yeah,
yes, sir. It is not in the full screen.
it's not in the full screen.
Yeah. Please click on the slideshow.
Okay,
Yes, sir.
yeah, sorry. So, as I said, that the LV function is described as either mild LV dysfunction, moderate LV dysfunction, or severe LV dysfunction. The problem with eyeballing is that the accuracy and the sort of reproducibility, they are observer dependent. So the sort of American Society of Echocardiography recommends that even an experienced echocardiographer should regularly cross-check his assessment with calibrated quantitative measurements. So here we can see that this particular screen on the left hand side, we can see that all these segments are moving very well. And so this is a normal LV systolic function. While here we can see that overall the LV function is depressed. So it is moderate. And here we can see that other than the sort of septal wall, all the other segments are sort of severely hypokinetic. So this can be classified as a severe LV systolic dysfunction. So this is by eyeballing. So now coming to the quantitative measurements one by one, the sort of fractional shortening is a linear measurement in which the LV diameter is measured just below or at the tips of the mitral wall leaflet in either the in the transgastric two chamber view, or exactly through the center of the LV cavity in the transgastric short axis view at the mid papillary level. So what we do is that we take the transgastric mid short axis view, and exactly through the center of that view we place we place the M mode, and in this we can get this particular M mode tracing. So from the endocardial border to the endocardial border, this is from here to here would be the LVI DD, that is in diastole, while here from here to here would be the LVI DS. It is important to know that this is the papillary muscle, so do not confuse this. So do not take the measurements from the papillary muscle. Be very careful to correlate the MO tracing with your 2D tracing and accordingly take the diameters. So when we substitute the LVID and LVIDS in this particular formula, we get what is called as the FS, that is the sort of fractional shortening, which is around 25 to sort of 45%. And the problem with the sort of fractional shortening is that it is not a sort of representative measurement in asymmetric ventricle, that is patient with severe RWMA or with aneurysmal dilatations. Now coming to LV wall thickness. So what we do is we take the transgastric mid short axis view, and in this particular view, we can either take linear measurements. This is about your posterior wall, and this is your septal wall, right? So in diastole, we will sort of freeze the frame in at end diastole, and we will take these two measurements. Alternatively, we can pass a M mode through through the sort of center of this, and here we can see from this to this in diastole. This would be your posterior wall thickness. Now about the sort of septal wall thickness, the problem sometimes is that because the angle of insonation here is not sort of perpendicular to the septal wall, many a times this measurement is difficult to get. Okay, so normal LV wall thickness is around 0.6 to 1 centimeters. Now we need this LV wall thickness to calculate what is called as the sort of relative wall thickness, which is measured by summating the posterior wall thickness and the septal wall thickness and dividing it by the LVIDD. If the septal wall thickness, as I said, is not obtained, we can double the posterior wall thickness and divide it by the LVIDD. The normal values are between 0.22 to 0.42. So we can see that the cutoff is 0.42. So what we do by getting this relative wall thickness is that we find out whether the LV is having concentric hypertrophy or it is having an eccentric, that is a dilated ventricle. Whenever there is an eccentric hypertrophy, the denominator will increase, and hence the relative wall thickness will be less than 0.42. Why is this important? This is because it is known that concentric hypertrophy is associated with higher incidence of cardiovascular events. So it is always better to write what is the LV wall thickness in addition to the LV sort of systolic function. Now coming to the sort of area measurement, which is the sort of fractional area change. It has a better accuracy compared to the sort of fractional shortening because more of the sort of LV is taken into consideration in this particular sort of measurement. So here we can see that in the formula, the LVI-DD is replaced by left ventricular area in diastole, and from which the sort of left ventricular area in systole is subtracted, and we get this particular fractional area change. The normal values are between around 55 to 65%. It is important that it is taken in the transgastric mid short axis view, and that the papillary muscles are excluded. So the RWMA will make a big difference only when it is severe, extensive, and it involves the apical segment, because we are taking it at the mid papillary level. So here we can see that we have taken this is in sort of systole. This can be correlated with your ECG, and this is in end diastole. So this is the end diastolic area, while this is the end systolic area. And when we substitute it in this formula, we get what is your FAC. Okay, so here we can see that these are the papillary muscles, and that the papillary muscles are excluded, means we do not take it this way. We always exclude the papillary muscle. This is very important. Now coming to LV volumes. Basically, volume is a three-dimensional measurement. And when we are going to do this three-dimensional measurement from 2D images, it needs certain mathematical calculations. And these mathematical calculations are based on certain assumptions of the geometry of the LV. So these sort of LV has been described in various geometrical models, and they have undergone rigorous validation studies. So when we do it from the 2D measurement, it can be either the sort of linear measurement or the planimetric measurements. Now, in the linear measurement, the most commonly used is the cubed formula, or what is called as the Tycho's method. So this particular measurement is based on an assumption that the left ventricle is the shape of a prolate ellipse in which the short axis is half of the long axis. So this is an assumption which has been made. So for this, we calculate what is called as the LVID minor, which is taken in the midesophageal four-chamber, two-chamber view, or in the transgastric two-chamber view at the tip of the mitral valve. So here we can see that this is the LVID minor. Okay, so when we cube this particular LVID minor, we get what the LV volume. The problem with this is that because it is a cube function, the small errors can be magnified, and as the LV dilates, we all know that the sort of LV becomes more spherical. It means that the LVID minor will increase compared to the LVID major. And as a result of which, we will get an overestimation of the LV volume whenever the LV dilates. Now, in the planimetric measurements, there are four methods: the single plane ellipsoid, the biplane ellipsoid, the bullet formula, or the area length method, or the modified Simpson's method. Now, these first three methods, they have been shown to work only in normally shaped and sized ventricles, but they always failed in clinical use with abnormal ventricles. And hence, in 2015, these are ASC EACVI guidelines have mentioned only the Simpson's method as a method of calculating LV volume. So let us see this, what is this.
Now the phone bantu off audio.
Hello? Yeah. So now let us see what is this modified Simpson's method. So in this method, basically, the sort of LV has been assumed to be a series of 20 discs from the base to the sort of apex. Two views are used: the midesophageal four-chamber and the midesophageal two-chamber views. And in this, the LV volumes are measured both at end diastole and end systole in both the planes. So the computer software package, it calculates the volume of each disc, which is calculated as the height into the area, and these volumes are summated to give us the total LV volume. Why is this better? It is because both the four-chamber as well as the two-chamber views are used, and hence it corrects for any sort of shape distortion and minimizes the mathematical assumptions. So therefore, in patients with RWMA or in aneurysm, in which the sort of linear measurements fail, the volumetric measurement by the modified Simpson method are better. The problem with this is that if there is the sort of foreshortening of the LV, then it will result in underestimation of the LV volume. So if the sort of apex of the LV moves along with the contraction, it is said to be foreshortened. If you find it is foreshortened, you have to sort of retroflex the probe so as to get away with this particular problem. Now, sometimes it is possible that the endocardial borders are not well seen. And if they are not well seen, then the modified Simpson method becomes a bit problematic. And in such cases, we can use the area length method. So this picture will show you that here the top two views are the end diastolic volume in four chamber and in the end diastolic volume in four chamber and the end systolic volume in the four chamber, which will give us this LVEF in the four chamber. Similarly, in the two chamber, we again take end diastolic and end systolic volume. So it will give you what is the LVEF in two chamber. And here we can see that it will give us the overall LVEF, which is 20% in this particular case. Now coming to the area length method. As I said that if the endocardial borders are not well seen, then this method becomes the method of choice. It is also called as the bullet formula or the sort of hemisphere cylinder formula, because here the LV is assumed to be of the shape of a bullet, which we can see over here. Now, this is the formula, that is LV volume is equal to 5 by 6 into the left ventricular area in the sort of short axis into the LVID major. So we take two views. One is the transgastric mid papillary short axis view, and in this sort of systole, we take what is the uh, end sort of systolic area. Here we see, and again we take the LVID minor. Yes, we see it is in the sort of systolic frame because your mitral valve is closed, and this is the LVID major. And when we sort of substitute these two values, that is 10.4 and 6.2 in this particular formula, we get what is the LV sort of volume by the area length method. Now, LV mass. Basically, what is LV mass? It is the volume which is encompassed by the LV epicardium minus the volume of the LV cavity multiplied by the density. It is preferably given as a function of the body surface area, that is, it is always per meter square. So in males, obviously, it is more compared to that in the females. And increased LV mass is a strong predictor than low EF for all-cause mortality and cardiovascular events. So LV mass many a times is not written. So in our hospital, we have made it compulsory for our echocardiographers to mention the LV mass along with the LV systolic function. Now, it should always be sort of reported in order to complement the overall estimate of the LV function. So again, it can be calculated either by the linear method or the 2D planimetric methods. The 2D planimetric methods again are either by the area length or the truncated elapsed or the Simpson's method. But here we can see that both these are very complicated. And as a result of this complexity, the linear method becomes the method of choice for calculating the LV mass. So what we need in this, we need three parameters: the LVID major, the posterior wall thickness, and the septal wall thickness. And when we substitute it in this particular formula, we get the LV mass by the linear method. It is not preferred because it is obviously inferior to the these are planimetric method, but because it is simple and has a superior reproducibility, it is most commonly used. However, what we have to do practically in the machine is that we have to acquire the transgastric mid short axis view, and then we have to trace the that particular tracing we have to do at the epicardial level and the endocardial border. And the LVID major is calculated in the long axis view, and the software in the machine calculates the LV mass for us. Now coming to dP by dt. So what is this? So basically in the isovolumic contraction phase, the maximum rate of rise of LV pressure is a good measure of the LV contractility. So it is measured by the simplified Bernoulli equation. For this, presence of mitral regurgitation, some amount of mitral regurgitation is a must. So in this mitral regurgitation Doppler velocity profile, we see what is the rate of rise from 1 meter per second to 3 meters per second. And then by this sort of simplified Bernoulli equation, we get what is it is 32 divided by the dt. So dt is basically the time interval for the pressure to rise from 1 meter per second to 3 meters per second. So as the sort of dt goes on sort of increasing, it means that the LV sort of function is decreasing. So this LV dP by dt, so this is the actual trace how we do it. So in the presence of MR, we see so from 1 meter per second to 3 meter per second, and this will give you either it will directly give you the dP by dt, while in some sort of machines which are not very advanced, you can at least calculate what is the time from 1 meter per second to 3 meter per second, and then 32 divided by the dt, we can get what is the actual dP by dt. So, sort of as I said, the disadvantage is that it does need some degree of MR. So in the absence of MR, we cannot calculate dP by dt. Also, but the sort of advantage is that it is not affected by afterload, and it is minimally influenced by the preload. It is not an accurate marker when there is presence of an acute MR in which there is an increase in the marked increase in the LA pressure. Also in patients with left bundle branch block, or in RV pacing, or in WPW syndrome, these values may be incorrect. The lower values which are seen in these particular patients may be due to dysynchrony and not necessarily due to decreased contractility. So the normal dp by dt values are when it is more than 1200, borderline when it is between 800 to 1200, less than 800 is decreased or reduced LV function, and when it is less than 500, it means that it is severely decreased LV function. So now coming to tissue Doppler imaging. In this, what we calculate is that the peak mitral annular descent velocity, PMAVD. Okay, so this correlates well with the global LV function, even though it is preload dependent. Studies have shown that a lateral wall PMAVD of more than 5.4 centimeter per second correlates with an EF of more than 50% with around 85 to 89% sensitivity and specificity. If we take these at 6 different sites, lateral, medial, inferior, anterior, posterior, anteroseptal, and if we sort of summate it, then the specificity increases to around 97%. So here we can see that this is the tissue Doppler imaging trace, which is placed at the lateral wall, and your PMA-VD is actually this S prime. This is your PMA-VD. So because it is a tissue Doppler imaging, it does have its angle dependency problems, which can be overcome by the strain and strain rate measurements, which we'll be seeing later. Okay, now PMAVD is closely related to MAPSE, that is mitral annular plane systolic excursion, which measures the distance that the annulus travels, while PMAVD measures the velocity of this particular motion. So MAPSE is the distance, while PMAVD is the velocity. Now coming to MAPSE. So it basically measures the mitral annular movement towards the apex during systole. It is a surrogate of LV longitudinal function. So it is a poor man's GLS, which we'll be seeing later. So these measurement is done with the M-mode beam position on the mitral annulus. Now what we do is this. So we place an M-mode at the lateral lateral annulus of the mitral valve, and when we get this trace, so the measurement from year to year. So this we can see, this is your mitral annular plane systolic excursion, which is around 1.2 in this particular case. So Deepak Borde and his colleagues, they have published a paper in which they have mentioned a cutoff value of 9 millimeters for lateral and just 7 millimeters for septal as an estimate of the LV function, and this is with more than 80% sensitivity and specificity. So this is a poor man's GLS. Now, the sort of advantage is that it is easily doable, and but the problems are preload and angle dependence, LV foreshortening, and it is not accurate in patients with severe RWMA, LV hypertrophy, mitral valve calcification, and in chronic atrial fibrillation. Now the TI index. The TI index basically is a parameter of global LV ventricular of the global ventricular performance. It means it is non-specific. It cannot differentiate between systolic and diastolic dysfunction. So the MPI is basically calculated by adding the isovolumic contraction time and the relaxation time and dividing it by the ejection time. It has a normal value of around 0.39 plus minus 0.05. Now, why more than 0.5 is abnormal? Because as the LV systolic dysfunction sets in, the IVCT increases and the sort of ejection time decreases. So the ejection time means the denominator decreases and the numerator increases, and hence this particular value increases. So to calculate this, we need the deep transgastric long axis view, and the pulse wave Doppler is placed in such a way that we should get both the LVOT outflow as well as the mitral inflow. So when we get this, as we all know that the time from the end of the mitral inflow to the beginning of the LVOT outflow is the isovolumic contraction time, while from the end of the LVOT outflow to the beginning of the mitral inflow is the isovolumic relaxation time. So if we can either take both these two separately and the ejection time separately and add this, or what we can do is that we can take the distance from the end of the mitral inflow to the beginning of the mitral inflow. So that is A, and the ejection time is B. So A minus B divided by B. So that is more simpler as compared to getting these two values separately. So it is very important to get this view and to place the pulse wave Doppler so that we obtain both LV outflow as well as the mitral inflow. Now the LVOT outflow track ejection acceleration. So what is this? So we get the LVOT outflow trace, which we all know that we can do by placing the pulse wave Doppler 1 centimeter inside the aortic annulus, either in the deep transgastric long axis or the transgastric long axis view. And from there we get two values, the LVOT Vmax as well as the acceleration time, and the normal values are around 8 to 14 meter per second. Okay, it is not load dependent. That's the advantage of this. So how do we do this? So we have taken this LVOT outflow track, Doppler velocity profile. When we trace this, we get the LVOT Vmax value, which here is 0.66 meters per second. And going to the time function, from the beginning of the LVOT Doppler velocity profile to the peak of the Doppler velocity profile, we take this time. So this time is 104 milliseconds, which we have taken as 0.1 milliseconds. So this LVOT ejection acceleration becomes 6.6 meters per second. So there is a mild LV systolic dysfunction in this particular case. And I am going to talk a little in detail about this strain and strain rate, because this particular parameter is gaining importance day by day. This is because, why is it gaining important? Because LVF has got numerous limitations, that it is load dependent, it has got a significant inter and intra observer variability, and basically it does not reflect the intrinsic myocardial contractility. Okay, so sometimes it may happen that there is LV dysfunction, but the overall LV systolic function appears to be normal. Okay, now as we all know that there is a complex orientation of the myocardial fibers in such a way that they are more longitudinal in the subendocardium, they are transverse in the mid myocardium, and they are oblique in the epicardium. And like a sort of ringing type of an action, the sort of LV contracts, and there are and there is an output from the sort of LV. Right, so here we can see this is how the myocardial fibers they are sort of arranged. Now it can either be done by 2D or by 3D. Okay, so in by the 2D speckle tracking, it is like a function of the tissue Doppler imaging, and in this we which sort of measures the myocardial velocities and the various deformation parameters like the strain and strain rate, they can be measured. Okay, so it measures the myocardial strain in three spatial directions. One is the longitudinal, second is radial, and third is the circumferential. The advantage being it is independent of the angle of insonation of the ultrasound beam. Okay, the left ventricular global longitudinal strain, that is GLS, is sort of measured from the axial or the long axis view, while the sort of radial and the circumferential strains, they are measured from the short axis view. Basically, this speckle tracking is an offline method. So the recorded loops are sort of processed by a software where the myocardium is traced and tracked throughout the cardiac cycle, and the software then calculates the strain and other deformation parameters. Normal values, they sort of still vary from publication to publication and the type of equipment used. However, there is a consensus document which says that the normal range is, say, maybe minus 18.5 for longitudinal, plus 44.5 for radial strain, and the longitudinal strain rate is 1 meter per second, and the radial strain is around 2.45 per per second. Okay, so this particular so strain and strain rate, they are color encoded, and they may be displayed either in the bullseye fashion or they may be shown as curves. Okay, the biggest disadvantage of this strain and strain rate measurement is that it is vendor dependent. So, because the global longitudinal strain has gained importance in recent times, I'll be discussing a little in detail about the GLS. It has got the largest body of evidence in clinical practice, mainly because the axial views have better lateral resolution than the short axis view. Then it is obtained from the entire length of the left ventricle, and hence it includes a greater amount of the myocardial tissue. And the radial and circumferential strains have demonstrated to have lower reproducibility than the LV-GLS. And hence the ASC-EACVI 2015 guidelines have recommended GLS as a reliable reproducible index of LV of this global LV systolic function. Now, what is GLS? It is a change in the length of LV in a certain direction, which here is longitudinal as related to the baseline length. It is a variation of the tissue Doppler, and it provides evaluation of regional myocardial function. It is an early predictor of regional LV dysfunction. Why is this? It means that as I said, that the contractile dysfunction is it will occur even before the EF drops. So as I said, that there is myocardial dysfunction, but the EF appears to be normal. Why does why is there a contractile dysfunction? First, because the subendocardial fibers are more susceptible to ischemia, and these fibers in the subendocardium are oriented longitudinally, and hence the GLS is affected first. Even and why is the LV appear to be normal is because of the compensatory increase in the sort of circumferential fiber function, which occurs as a compensatory method, and this compensation makes the LVEF appear to be normal, even if there is the LV systolic or LV myocardial dysfunction. So, the GLS measures the shortening of myocardium as a correlate of contractility, in contrast to the ejection fraction, which basically measures the volumes. Okay, now to get the GLS, we need the myocardial length in systole and in diastole. And as the myocardial length in systole is lesser than in diastole, the GLS values are negative. So a more negative value will mean that the LV contractile function is better. So as I said, that guidelines here do not have any specified value, but around 20% plus minus 2 may be considered to be normal. As it goes more towards 0, there is onset of LV systolic dysfunction. It is heart rate dependent, and tachycardia is associated with lower LV-GLS values. The angle dependence problem remains, and in hypertension, diabetes, obesity, the LV-GLS decreases much before the decrease in the LVEF. Now, the 2022 ESC guidelines on cardio-oncology, in which they have added the new relative decline in GLS by more than 15%. From the baseline, this particular thing has been added in these guidelines in addition to the other parameters about the LVEF. Okay, but however, even though this has been added, the impact on management is yet to be sort of validated. So even in our hospital, they for all oncology patients who are on chemotherapy, they as is mentioned, they have to undergo serial echocardiographic measurements or echocardiographic basically or assessment, in which we mention the GLS values from time to time. Now coming to 3D speckle tracking. So all that we said till now was 2D speckle tracking. Now 3D speckle tracking can capture the motion of the speckles independent of their direction. Here a significant higher number of segments can be analyzed, And the advantage is that the 3D ST measurements of LV volume, they are comparable with the MRI values. However, the greatest pitfall is the dependence on image quality. If you don't have a good image quality, basically it is true for all the 3D echocardiography that a good image, 2D image is always important. Now coming to 3D echocardiography. Okay, so it is highly accurate and advanced method of assessing LVEF. Here, a full volume data set of the LV is obtained in the longitudinal plane using a matrix array transducer. Depending on the patient's heart rate and rhythm, these images are captured over multiple cycles, which is called as multi-beat acquisition, or in real time, which is called as a single beat acquisition. Now, the endocardial borders are then traced through using automatic or semi-automatic methods to reconstruct this LV cavity in a three-dimensional form. And from this, the end diastolic volume and end systolic volumes are measured, and LVF is calculated by our standard formula. That is end diastolic minus end systolic divided by the end diastolic volume into 100. Now, the advantage of 3D echo is that real-time images can be created. It does not rely on the geometrical assumptions. It is unaffected by plane positioning errors and foreshortening. It is more accurate and reproducible. It highly correlates with the gold standard, that is the through MRI, and there are lower intra and inter-observer variation as compared to the 2D echo. However, it is not without any disadvantages. It is highly dependent on a good image quality. It has got lower temporal as well as spatial resolution compared to 2D. It needs an advanced equipment and software. There is reduced feasibility in the presence of other arrhythmias, and there are no standard values yet which have been agreed upon. So thank you very much for your patient listening. No?
Hi, that was a lovely talk. Excellently done. All the aspects of Elvis systolic function were covered in a short time. And I'm grateful to Dr. Nilesh for joining us and giving us the insight into LV systolic function. So I request Naina, Kadam, and Prashant to take the lead and continue the discussion. Any questions and comments are welcome. Actually, it was quite well done, so I have no questions to ask. Naina and Prashant. Anybody else wants to add anything or comment, ask questions, please feel free. We have about 15 minutes to go.
So just one point to add. The 17 segment model of the LV,
Yes.
depending on the blood flow distribution, which can help us understand like which area is affected, the regional wall motion abnormality. 17 segment model.
Sure. Nilesh, you want to respond to that?
Yeah, no, I think I could have added that also in my talk. So possibly next time if I give the same talk ever again, I'll definitely add it to it. So
Yeah.
I thought that would come in our sort of basics, that there are 6 segments at the base, 6 in the mid, 4 in the apical, and 1 apical cap, and then
Sure.
both in the sort of short axis as well as the long axis. Very famous diagram which is there and which every one of us has to know. So that particular thing can be added in the sort of introduction, which I would possibly do it the next time.
Great.
Good morning, sir.
Yes,
It's a
yes,
Good
nice,
yes,
morning.
nice
Prabhu.
presentation.
Yes.
So, what is the this one? What is the important of assessing the wall motion score index or score wall motion score?
Yes. So, as I said that there is, as the Naina mentioned that it's a 17 segment model, and each of them we got a score. There is one for normal, two for mild dysfunction. I mean, mild, moderate, and severe, two, three, four, and for dyskinesia we give as 5, and from there we can calculate what is the total score.
Yeah, that
No,
is
anything.
usually.
When what score it is? This one is this one grave. This one will be there. Suppose the patient's undergoing CABG. You understood my question, sir?
Yeah.
Yes, yes, the wall motion score index of 1 is normal. If it is greater than 1.7, it is associated with heart failure. And the wall motion score index is a semi-quantitative numerical derivative to express the left ventricular systolic function. And it is probably a little more better than, and you can always use this left ventricular wall motion score index to correlate with the prognostic outcomes. Thank you for that point.
So the one more question,
Anybody
sir.
want to add anything to this
Anything
question? Yes.
anything replacing the ejection fraction when compared to other? Still, what book says? Still, ejection fraction is the good parameters when compared to all. Is it so or?
No, now the global longitudinal strain is coming up in a big way because, as I said, that yeah, it decreases much before the LVEF decreases.
I agree. It is more sensitive than ejection fraction. In fact, EF may be normal, but global longitudinal strain may be reduced in the beginning of left ventricular dysfunction, which may not be manifested in the simple ejection fraction estimations.
Yeah,
Sanjeevani, do you agree with?
Yes, yes, yes. Nice presentation, Nilesh.
Thank you.
Can I add one or two points?
Yes, yes, yes. We
Mhm.
have about 7 minutes to go.
I just
Please.
practical implication of whatever we are saying that GLS is better than EF is in especially in aortic stenosis when to intervene surgically.
Yes,
We have started doing GLS rather than EF, and the moment GLS drops, one should take him for surgery
sure.
or just
Actually,
try
one of
that.
my
That is
Yeah,
very,
because
and that is same.
yeah, and
Huh. Yes, yes,
yeah,
Nilesh.
so why this GLS, as I had mentioned, is that whenever there is ischemia, it is the subendocardium which is affected first, and in subendocardium these fibers are arranged longitudinally, and hence your GLS drops. But because of the compensation by your circumferential fiber, because that is your radial and circumferential strain, the LVF the EF appears to be normal.
And
So
on
that's
the
why
contrary,
GLS has got more importance than EF.
yes, yes. On the contrary, in severely concentric hypertrophy patients, EF is more 70%, 75, 65
Yeah.
because of radial fibers. So it may be super normal. I mean, have you thought of myocardial work just as a theoretical discussion, we will say, or maybe it will come practically also, because they say that GLS, if you don't see blood pressure of patient at that time, if it is very high, then GLS maybe, it may fool you. Myocardial work. When it is compared with systolic blood pressure and GLS, both are compared at the same time.
Sure.
Yeah, there is when there is increased mitral word, there will obviously be some tachycardia, and as I said, in tachycardia, the GLS values are always underestimated.
Correct, correct. So this is one important. If patient's blood pressure is very high, it can even GLS can be fallacious.
Yeah.
So you have to wait, reduce its blood pressure precariously, and then take GLS. Nice. Good.
Yes. Any other questions or comment? I think I'll just go through
What
the
practically would
Naina, do you want to go through the chat box and complete it? Yeah, so you were saying something else,
no, what
Doctor.
practically when I take this MAPSE, when you compare it with TAPSE is a better indicator of RV function as compared to MAPSE for LV. For the simple reason that the movement is very less because of the bullet. And here it is a crescent shape RV and very thin walled volume pump. So the movement is very large. So TAPSE for a RV is a better thing as compared to MAPSE for LV. And when this is my practical observation that MAPSE many a times comes quite high, 12,
Yeah.
13, 14, even though patient is otherwise having low EF. Maybe angle
Yeah.
is wrong or many things.
The main thing is that whenever there is severe apical problem, the base still continues to contract well.
Yes.
Yeah.
Longitudinal.
So because the base continues to contract well, you get a good MAPSE values even when there is severe LV dysfunction. So that's why it has not gained as much of importance like TAPSE.
There's
There
one
is one
question by
question. Which measurement is more preferable to calculate systolic function in normal heart and severe LV dysfunction and in mitral valve disease? Actually, that's I usually ask in these sort of lectures, how do you estimate LV function in patients who have MR? The ejection fraction may be 55% or 60% on the echocardiography. But is that a true reflection of the LV function in the presence of MR?
No, it is always in the presence of MR. LV is always overestimated. The
EF
LV,
is always
yeah.
over.
So there, I think
So
dP by dt can definitely sort of help us.
And in
does
MR
that answer this
cases,
question?
Muralidhar, one point
Yes.
for this
Yes.
MR. In MR cases, shape of the MR is very vital in this scenario. If it is triangular, not tongue shape, that means certainly this patient and his gradient is have started reducing rather than increasing. That means LV is failing. It may not give you actual number, but LV is not good. If it is a conical, triangular, rather than tongue shape. Tongue is the normal shape of MR. Good with good LV ejection.
Sure. Any difference in LV volume if we calculate TEE apical 4-chamber and apical 2-chamber view and transesophageal 4-chamber and 2-chamber view? That is basically the LV volume comparison of TTE and TEE in 4 and 2-chamber views. Is there any difference?
If there is no foreshortening, there should not be any difference in that. So we have to take care about the foreshortening. In T, the foreshortening is very common.
Yes, yes. I agree. I agree. I also will say that the volumes may be um, influenced by the loading conditions, which are different in anesthetized patient. So the slight variation is expected. I would like to say like that. Because the afterload is different, the preload may be different. So though the contractility may be same, so the volumes may not be exactly same as you compare the awake conditions with anesthetized conditions. Do you agree, Sanjeevani?
Yes, yes, yes.
And there's one question on, can we use above parameters in patients with AF and mitral valve disease?
Which parameters?
I think LV systolic function parameters. That's what I would guess.
No, we have if
Talk
they
on
Yeah, it can
modified
be used.
Simpson and AF. You speak on modified Simpson
It
and
can be
AF.
used, but only thing is because if the stroke volume will be different for each beat, you have to take average of 5 to 10 beats and then say that this is the stroke volume for a given patient.
Sir, one
Prashant
thing, sir.
wants to know better.
Yeah,
Yeah.
sir, in vasodilated or a post-bypass period, whether we should go for a volume independent or a volume dependent things will be the best, will be the superiority, which should be the superiority, sir. Like EF, whether it's applicable in the post-bypass or vasodilated state, or we should go by DPDT, which is volume independent state. Which one will be the preferred way to go for assessment, actually?
Dr.
no,
Nilesh, please answer this.
yeah, sorry, anywhere, not only CPB, anytime if it is volume independent parameter will always be better than volume dependent parameters. Okay, so so dp by dt you will only get if there is so central MR. If there is no MR, then dp by dt values you will not get. So EFs. So your this thing called EF will still remain the method in by which you can calculate what is your LV systolic function.
No, my question is, sir, if in a vasodilated state, the EF measurement will be not accurate, how will you assess the individual, like, if DP by no MR, then how can
No,
we assess the systolic function, actually?
no, I really did not get your question. So, sorry, you are assuming that your patient is going to be vasodilated only.
In the general, yes, sir. If they are post bypass period,
Uh,
if a patient is
uh,
vasodilated, if you want to measure the EF
no,
in
but
post bypass,
EF means whatever the EF at that particular time you are going to get. No, what is the LV function at that particular time?
EF is likely to be good because the heart is going to empty or more or less fully because the low SVR. And usually the textbook description is that in vasodilated state, end-diastolic volume is normal and end-systolic volume is decreased, whereas in hypovolemia, both end-systolic area and end-diastolic area both will be decreased in hypovolemia. Do you agree with that, Nilesh?
No. Yeah, but I really did not get that particular question. What you said is correct, but
I think he
in
wants to know the
sir,
after
basically I wanted to stress
independent.
it. In post bypass period, the what we
Yes,
measure
yes.
the EF will be more overestimated compared to the what will be the when not in the normal phase. I wanted to specify, sir. Actually, that's what I wanted to
Yeah,
say that.
Sir,
yeah, because
what
if
my
you're
suggestion is,
if you're
sir, what my suggestion is, go for preload independent, the other dimensionless. This one that gives for his that gives that we can assess the exact result the what values when compared to the according to his question. We have so many other independent preload independent. This one is there, no, sir. That we can assess, and we can assess the ventricular function.
thank thank you, Dr. Prabhu. Final comment by Nilesh. You want to say anything on this issue?
no, I was feel that whenever the patient is vasodilated, obviously the heart will have less workload to do, so the heart will have a little slightly overestimated LV function than actual. But how much it translates to clinical use, I have no idea.
Here we have to see blood pressure. If even if the injection is good and if BP is 80, 70, then what is the use of that EF, So one has to see how severely he is dilated. SV, how much is the SVR? And try to correct it and then do ejection. That is the simple method. And this last question is also there. Prashant Pandit. That is a good question. What is
Totally
the
agree.
better?
You have to go. I agree totally. Go for of diagnosis. Systolic volume, diastolic volume.
That's a good question.
What is the question?
Yeah,
Because
Nilesh, you want to take this?
sir, I'll just go to the question.
What is the better marker of prognosis? End systolic volume or end diastolic volume, and why?
I think you have to take both the
Yeah.
parameters to be able to derive the ejection fraction. One single parameter will not be able to tell us what is happening. Unless it is abnormally increased, we can say that end diastolic volume is increased and end systolic volume is decreased, or whatever is the go by the nomogram and determine whether the volumes are increased. What's your response, Nilesh, for this?
Yeah, the basically if your end systolic volume is more, it means that your LV is not emptying well. So if we have to just say theoretically between these two, I would say end sort of systolic volume, if it is more, then it is bad as compared to the end diastolic volume. But as the LV goes on failing, the LV will dilate, and then the end diastolic volume also will go on increasing. So whenever we see that the end systolic diameter is more than 40, we say that this LV is dilated now. So later on, we will see that the LVI DD also goes more than 65. So the first thing that happens is that the end or systolic diameter that will increase whenever the LV starts dilating.
Sure.
Can I say something on this?
Yes.
See, all these studies, cardiological studies and graphs, they are on end systolic volume pressure curves. So end systolic volume is more sensitive. And end systolic volume, they calculate by modified by Simpson. And if it is more than 25 ml per meter square, certainly that LV is not that good. So initially they calculate only end systolic volume. End diastolic volume is obvious and it does.
That brings in the subject of arterial venous coupling, arterial ventricular coupling.
We are not able to hear you.
Deal with next, cause that is a ratio of the end systolic elastance and arterial elastance. That ratio is relationship between end systolic elastance of the left ventricle in next session. And thank you so much. Time to close the session. I would like to thank Nilesh for that excellent talk, and Naina and Prashant for being with us, and contributions from Sanjeevani, Prabhu Shankar, and others. Thank you so much, and we look forward to having you again next another topic. Thank you so much. Very well done. Before we close, I think Rimpa will play the IACTA TE video, and then we'll close for this today. Thank you.
Sure,
Thank you,
sir.
sir.
Sure. Just allow me a moment. So, thank you so much, everyone, for joining this session. Clanet is really glad to have all these brilliant people together. So, with all your permission, I'm closing the session for today and looking forward to hosting you again. Thank you so much, everyone. Have a great day.